Hello, Alex.
Hey, can you hear me?
Yes.
Hey, so my name's Alex Smith. I'm an intern in internal medicine at the Northwell Health System in New York on Long Island. I'm excited to be with you guys tonight. Thanks for having me.
Great. And Drew?
Hello. I guess bit of a schedule change since I was going to be going next week, but Stephen had
Just introduce yourself, Drew.
okay, will do. I am a fourth year at Virginia Commonwealth University, the old MCV, as Uncle Bob would say. And this is my my second time discussing. No, sorry, my third time discussing on the show. And well, let's get started, I guess.
Jeopardy champion.
Although he needs no introduction, Joel, introduce yourself.
Hey, my name is Joel Topf. I'm a clinical nephrologist in Detroit and spend a lot of my time doing medical education through innovative new technology. So I'm honored to be here. Pretty excited to see what this is like.
Okay, so here's the setup for Alex and Drew. Your resident says, we got a new patient down the ER. I'm going down to work another patient up, look them up, and then go down and talk to them. You sneak on the computer and you see this basic metabolic panel. So what I want you to do is, what information can you get from this metabolic panel, and what ideas does that get that is going to drive you to figure out what kind of history you need? What are the questions you have just by analyzing this metabolic panel? And I guess we start with students first and interns second.
Okay.
So Drew.
Yeah, so first thing that I want to look at is that bicarb's jumping out to me.
Okay.
I'd want to calculate an anion gap, and it seems like it's been calculated, 14. So check an albumin as well, just to make sure that 14 is a legit anion gap rather than, oh, this patient has more albumin than we would be used to. The other thing that I notice is that his creatinine is up. I'd want to get a baseline to see if he has CKD, or if this is an elevation in creatinine that is acute. And then I would want to see if it's fluid responsive. If it isn't, then we have an AKI on our hands. We have to figure out what the source is. BUN to creatinine ratio, I think, is close to 10-ish. So suggesting I think it suggests an intrarenal cause if this is an acute kidney injury, but we'd have to give him volume first just to see.
Yeah. Okay, so Alex, now that you're been an experienced physician for at least 3 months.
Not quite, but thank you. Yeah, so I agree with Drew. Bicarb definitely jumps out. Anion gap of 14, and the creatinine, we want to figure if this is a new elevation in creatinine or something more chronic. I guess another thing that we could do that maybe Drew hadn't mentioned yet was look at urine electrolytes. If the patient is on a diuretic, then we would want to look at fractional excretion of urea. If he or she's not on a diuretic, we could potentially calculate her fractional excretion of sodium. Do a physical exam to try to assess volume status as best we can.
So neither one of you have mentioned history. So Joel, when you see this, what thoughts do you have, and teach them how you would approach this if somebody calls the consult and they just said, I don't like this BMP. I need your help, Joel.
Well, I thought both of them did a fine job. I think they hit all the important points. But to me, the lab that's most abnormal is the bicarb. And I get uncomfortable. It does have a positive anion gap, but let's face it, the anion gap is not very high. You know, an anion gap of 14 with a drop in the bicarb to 15. So you have a much greater drop in the bicarb then increment in the anion gap, right? And so that suggests that there is going to be there's some non-anion gap component. And once you have a non-anion gap component, then all bets are off if you actually even have a metabolic acidosis or not, right? We don't know that we have a metabolic acidosis because we don't have a pH. And so I'd be pushing, looking at this ABG to get, looking at this basic metabolic to get an arterial or venous pH, just to get my sense of which direction, are we going to go down the rabbit hole of metabolic acidosis when what we actually have is a compensated respiratory alkalosis dropping that bicarb. And you want to get that out of I want to do that sooner rather than later, because it's just going to shift my entire differential in terms of what I'm thinking about.
How do you decide between arterial blood gas and venous blood gas?
So I don't care, right? Because all I'm looking at with this test is the pH, right? Is the pH shifting down or shifting up? If it's shifting up, it's going to be a respiratory alkalosis. If it's shifting down, it's going to be a metabolic acidosis. Where the big difference between arterial and venous is when you're going to be looking at the blood gases, when you're really worried about the respiratory function. Are you going to need to intubate? None of those questions are, do I need to address here? But again, we don't have any history. Why is the patient here? So I would want to get a little bit more HPI. But in terms of what our discussants talked about initially, I thought they were right on. Well done.
So we'll give you VBG in a second, but why don't we give you some history and put this guy into context? Do you have it, Stephen, or do I need to try to remember it?
No, I've got it right here. So this is a 70-ish, this is a 70-ish-year-old gentleman who's with a history of Crohn's and chronic pancreatitis, who's coming in with diarrhea for several weeks.
And abdominal pain, Stephen.
And abdominal pain. Tell me.
Now you know who asked me about the patient. Okay, how does that help you, Alex?
So definitely the history of Crohn's sticks out. I'm wondering if the patient we know is actively having diarrhea right now. So I'm wondering if any component of this non-gap acidosis is coming from the diarrhea itself.
If it's a non-gap acidosis, we still don't have the VBG. We have it in our back pocket, but we're hiding it from you for right now.
Sounds good. I'm also wondering if so we know the patient has a history of chronic pancreatitis. I'm wondering if there's any reason this patient might have any acute exacerbation of this chronic pancreatitis, any reason why he might have some degree of fluid sequestration leading to an elevation in his creatinine. But we still don't know if it's acute or chronic.
Right. Drew, do you have any other thoughts at this point?
Yeah, so one thing that I was thinking of is that if he does have diarrhea, we could look at the chloride and see if there's any elevation. And I think the urine chloride may also help too. Because I think if I remember correctly, diarrhea is a bicarb and potassium losing process, and chloride goes up. So you have, so it's a hyperchloremic non-anion gap metabolic acidosis.
Okay, Joel, do some teaching here.
Yeah. So, again, I'm still stuck on, I need to know whether I want to know that before we go down the metabolic acidosis rabbit hole, I want to know the ABG. I want to make sure we're not getting thrown off. Just because, especially when you hear the story about abdominal pain, boy, people in pain can hyperventilate. Do we have chronic respiratory alkalosis? I'm not going to, and I have been burned not myself, but I've seen too many resident teams start treating these bicarbs, this respiratory alkalosis with bicarb, and it drives me absolutely batty. That said, it sure looks like a setup for diarrhea-induced non-anion gap metabolic acidosis. That's the story that fits with our labs here. I would Dhruv, am I smart?
Dhruv.
Dhruv,
Yeah.
sorry about that, Dhruv. You're exactly right that diarrhea causes an elevated chloride, hyperchloremic acidosis, but you're not going to see that in the urine chloride. So urine chloride is not going to help you. You're going to use your urine chloride when you're working up metabolic alkalosis,
Wow.
and so not going to be super helpful in this situation. But again, I'm sticking on my initial question. I want to make sure we're dealing with metabolic acidosis going forward. And then the other thing,
let's give the VBG. We're going to give you the VBG right now because you keep asking for it.
Keep asking for it. I know.
Yeah, and that is a great lesson in and of itself. If everybody doesn't learn anything else from this entire session, the fact that you better find out if you're dealing with an acidosis or an alkalosis is a great teaching point. And I agree with Joel 100%. I've seen people start treatment and not consider that it might be, but in fact, this one is a metabolic acidosis.
Perfect.
Yeah, so for BVG, the pH 7.34, PCO2 27, PO2 is imaginary, and the bicarb is 14.
So you're happy, Joel?
I am.
Good.
Right, and then you run Winter's formula on your ABG to see if you have a concomitant respiratory disorder, and we're in the house, right? Take 1.5 times the bicarb of 14 gives you 21. Add 8 to that gives you 29 plus or minus 2, 27 to 31. Actual PCO2 is 27, so we're fine there. So we've got a pure, well-compensated metabolic acidosis. He does have an elevated anion gap, which at the upper limit in most modern day hospitals, upper limit of normal for anion gap is going to be 12. His is 14. But we talk about, we expect the anion gap to go up by 1 for every 1 that the bicarb falls. In this one, the bicarb has fallen 9 from 24 to 15. And the anion gap has gone up by a couple, maybe a couple more if you've got some hypoalbuminemia, which we don't know, hypophosphatemia, which we don't know. But this is looking like a largely a non-anion gap metabolic acidosis with a small component of an anion gap metabolic acidosis.
Could you, Joel, I hadn't heard that before. I want you to explain that again, because I think that's a really interesting point. So I develop a normal gap acidosis, and you say my anion gap goes up a little bit for each drop in the bicarb?
No, this is for if you have an anion gap metabolic acidosis. Right. For every 1 that the anion gap goes up by 1, the bicarb should fall by 1. Mm-hmm. Or you could flip it around. For every 1 that the bicarb falls, the anion gap should go up by 1. And that's what happens with an anion gap.
Right.
And so you want to see the change in the bicarb equal the change in the anion gap. This is the basis of the delta calculation, right, or the gap calculation, mm-hmm, right? And so, I look at the change in bicarb, 24 to 15, that's a delta of 9. And I look at the change in the anion gap starting at 12, going to 14. That's a delta of 2. Oh, those aren't the same. And when they're not the same, that, in this case, when you have if you have a much greater drop in the bicarb, then you have a big non-anion gap metabolic acidosis. If you have a much larger increase in the anion gap, then you have a pre-existing metabolic alkalosis. That means that the bicarb started way higher than 24 to begin with.
Now, with additional history, he has had an elevated bicarb, an elevated creatinine in the past. Not quite this high. I think it was like 1.5 or 1.6. Is that right, Tavo?
Yeah, it fluctuates, but probably his baseline is in the 1.5 to 1.8 range.
And now it's gone up to 2.5. So I'm just going to let Joel, why don't you pontificate on that?
Well, so we've got kidney dysfunction, and the first thing that I always reach for in that situation is a urinalysis. We get a lot of information from a $2 test, right? I got urine, gives me a sense of the specific gravity, which is going to help with whether the patient has a pre-renal component or a volume responsive component. We'll be able to take a look at the urine pH and somebody's got a metabolic acidosis, especially because when we think about that non-anion gap metabolic acidosis, bouncing around in our head, besides diarrhea, could this patient have a renal tubular acidosis? They already have an autoimmune disease with the Crohn's going on. So I'd like to see, we would expect urine pH to be very low. So that would be interesting. And then white cells, red cells, casts, all that will be surfaced with the urinalysis. So that's the next thing I ask for. But given a patient with a history of diarrhea and a history of pancreatitis, boy, it sounds like this patient is screaming for some IV fluids, right?
Mm-hmm.
Right. He gets IV fluids. He is not obstructed. Everybody, a lot of people in the chat are asking for, is he obstructed? And obstruction is ruled out.
Walk me through. I'm interested about the people in the chat. Why are we thinking what in the history makes you think obstruction?
Just a disclaimer, we didn't think about obstruction in the team.
I would. I mean, this story doesn't scream it when it comes to beginning. It's easy to do a bladder scan. It's easy to do an INO cath. But when I hear this history, unless the patient had, very high blood pressure that we don't normally expect in this patient, you think he has urinary retention. Is there something that I'm missing?
He's in his 70s.
Ah,
yeah.
Good guy.
Actually, when I go to make rounds, they do a bladder scan on me most days. At least I think the chat wants to. I'm not sure.
The problem is he stops in the bathroom every 10 minutes, so we are always concerned about Dr. Centaur.
Yeah.
I'm sure he's just tweeting in there.
Yeah, this is going. So my friends are putting all these comments on Twitter now. It's really great. So they give him volume over time. His creatinine drops down with volume. He's having 5 to 6 loose stools per day. Looks malabsorptive. And additional history is this is a 60-kilogram man.
Oh.
Because of his chronic pancreatitis, probably from alcohol. But he also has Crohn's also. He's on appropriate medications for Crohn's. And so I think he settles down to about 1.5 as his creatinine. So with volume resuscitation, he goes from 2.5 to 1.5. His bicarb stays about the same, within 1 or 2 of this the entire time he's in the hospital.
Oh, he does. His bicarb does not get better with the improvement in the kidney function.
Mm-hmm.
Right. Right. But so he has a creatinine of 1.5. Given that he's a 60-kilogram man, so this is a tough one, Alex.
Yeah, but there's actually some interesting a couple of things. So one, that creatinine of 1.5 in somebody who has decreased muscle mass and decreased total body mass is much more significant kidney failure than it may look on the surface. Like, don't get fooled by your eGFR calculator. This guy probably has pretty bad baseline kidney function. GFR is probably in the low 30s, just eyeballing and just guessing. So that's one thing to consider. The other thing, people are hanging their hat on that BUN to creatinine ratio. When you have somebody who's got a history of alcoholism, possibly some liver disease, clearly not a great nutrition, their nitrogenous intake will be decreased, and you can't hang your hat on that elevated BUN to creatinine ratio like we normally expect. I'm not surprised at all that this guy was fluid responsive, even though he had a low BUN to creatinine ratio.
So let's talk about the estimated GFR for a minute. Alex and Drew, what do you know about the estimated GFR? And is there anything we could do to get a better estimation than what the computer tells us?
So I guess I'm going to go a little bit on a soapbox here, but there's been a big push now by a number of institutions, and it started at least this past couple of years, or like within the past couple of months or so, but sort of the advocacy has been going on for a little while, that the eGFR calculation using the Cockcroft-Gault equation, there's a correction factor that is applied for patients who identify as black, and
That's not Cockcroft Galt.
That's not Cockcroft
That's
Galt.
oh, it's not
that's-
Cockcroft.
That's MDRD and
MDRD,
CKD Epi. I'm sorry to correct. I just want you to
No.
Cockcroft Galt. They have lots of problems with Cockcroft Galt, but it's sexist, not racist. You got to get that straight, right?
Okay.
And just to let you know, probably in the next 6 weeks or so, I have a podcast coming out on why we should not use race in MDRD and CKD Epi. A very, very interesting editorial that was written in the Annals of Internal Medicine about this.
Who was on your podcast?
God, I can't remember. It's a guy it's a guy at is it Cleveland Clinic? I'll look it up while you're talking.
Okay.
So
Joe, that's what we do bladder scans on him.
Sounds like you need to do head CT.
Yeah, we tried that as well.
Right.
we probably need to do psychological testing too.
Mm-hmm.
Alex,
the other thing that I was going to
different equations, because I think this is actually really useful, is to know when not to use the equations and to know what the equations are.
Perfect.
Mhm.
Yeah. Was this one for me? I'm sorry. Did I?
So I'm going to let
intercept that?
Alex see if Alex
Yeah, Alex,
knows
go.
anything, and then Joel. I think this is really an important teaching point.
I definitely hear your points that this is a gentleman who's very underweight at baseline, so his degree of creatinine elevation is not going to be is not going to correlate to the same degree with his degree of renal dysfunction as it might for somebody who's has a much greater body mass. So I guess a better way to calculate, I guess we could calculate his creatinine clearance over 24 hours with a 24-hour urine collection. We could, I guess, in theory, we could give him a dose of inulin or something that's entirely cleared by his glomeruli, as opposed to something that'll have some component of renal excretion. That's what I was thinking.
Okay, so what is the problem? What is the assumption that is made in the estimated GFR that falls apart when you have? I mean, I had a guy the other day who had an estimated GFR of 300. You know, he had a creatinine of 0.4 and he weighed about 40 kilograms. So maybe if Joel could explain what MDRD is and what CKD Epi is and why they mess you up when you're sarcopenic.
Yeah. So first of all, the most important assumption for all these tests is that the creatinine is stable, that your creatinine today is going to be your creatinine tomorrow, which is going to be your creatinine next week. And clearly this guy fails that first assumption. He's in the middle of acute kidney injury. His creatinine was 2.5 one day and it was 1.5 the next day or a few days later. And so he does not have a stable creatinine. And that was a baseline assumption for all these equations from Cockcroft-Galt all the way through CKD Epi. And then one of the basic assumptions is that creatinine generation is constant, that every individual, individuals vary, but a single individual will make the same creatinine on Mondays, they'll make on Wednesdays, they'll make on Friday. And since the creatinine production is stable, the only thing that changes serum creatinine concentration is going to be creatinine excretion. And that's the basic assumption that allows us to look at the serum creatinine and estimate, their creatinine's rising, that means they have decreased kidney function. That's the basic premise of how serum creatinine works for estimating kidney function. But if you wanted to go from there, instead of just saying, what's the change in their kidney function, and say, well, what is their precise kidney function? Then we need to know how much creatinine is being produced. And there's been a number of ways to estimate that. And Cockcroft and Galt in 1976 did it by looking at gender, weight, and age. And actually, they didn't even look at gender. They had all men, and then they just, in the discussion section, said, well, women probably are smaller, so we'll multiply it by 0.85. It's the most significant, throwaway line in a discussion section. It's unbelievable that they got away with it. And so from that insanity, we then have MDRD. And MDRD is a result there was a massive a study that was done late 80s, early 90s, looking at blood pressure control and dietary protein to prevent the progression of kidney disease. It was a big bust. Neither blood pressure control nor low protein diets actually slowed the progression of kidney disease, but it was a big science, capital B, capital S type project. And as part of it, they did very accurate measured GFRs, not inulin clearance, but essentially something equivalent to an inulin clearance. They infused the patients and measured the clearance in the urine. And they used that data to then generate equations. And they looked at a lot of different variables. We used the 4-variable one, but the one that was originally published in Annals was an 8-variable formula that included BUN and albumin in addition to age and race and gender. And what Dr. Centaur is getting at was that race was very casually assigned in the study. They did not ask patients to self-identify, even though that's what the methods of the study said. We will ask patients to self-identify. What actually happened, if you talk to study nurses, is the study nurses looked at the color of their skin and said, "You're black, you're not." And
Oh, okay.
and so that's a little casual for something that's so charged. But there was a pretty profound difference in the creatinine generation between it with that variable, right? Because it's a multivariate regression. They looked at 30 variables, and race was one that came out. So there's something behind it, and what that something was that they had what appeared to be, what that something was is that they had a higher GFR for the same serum creatinine, which we extrapolate to mean they had higher muscle mass. Higher GFR for the same creatinine. Yes, that is correct. And then CKD, and the problem with MDRD was there was only about 200 black people in this study. CKD epi has about 2,000 black people in it. Same idea. About 10 years later, they looked at the data, and again, race, and in this study, it was actually pooled from a lot of different studies, and some of them had more casual assessment of race, and other ones had more precise measures of race. But and the display, it's about a 20% bump in GFR for MDRD and about a 16% bump in GFR for black participants in CKD epi. The difference goes down a little bit, but still a pretty significant difference between them. The reason people are
Joel, one second.
Yeah.
I put a link to the article that I did that the podcast is coming out on in the chat. It was Ash Segal, Ashwini Segal at Cleveland Clinic. It's a very interesting, and one of the things he points out is how big the confidence intervals on all this, and how much the confidence intervals. He makes the argument that because we're not really looking at muscle mass, we're assuming everybody has the same muscle mass, that the real confidence intervals on any of the eGFRs is pretty wide.
Yeah, and that's a good point. It doesn't matter what race you are, what age you are, what gender you are. These things that we talk about, oh, you're 47%, it is plus or minus a lot, 15 or 20 on those numbers. It's not nearly as precise as we give it credit for.
So I actually did a Cockcroft Galt on him when he got down to 1.5, because I figured that would be a little bit more accurate since he was sarcopenic. And that, I think it came out to like 35 or something like that, exactly what Joel guessed. Why is that important, Joel?
Well, again, when these people's GFRs get low, you just want to be conscious of that, because we sling around a lot of medications in the hospital, and sometimes when you see a creatinine of 1.5, you don't think that you need to worry about kidney dosing because it's a relatively close to normal serum creatinine. In some hospital systems, it won't even be flagged red or with an H, and you just need to be aware that the patient that you're dealing with, that's actually pretty low kidney function. You need to be aware that you're dealing with somebody where you need to consider whether you should be giving this patient baclofen as an example of a drug that you run into trouble with all the time, or cefepime, a drug which we normally do have no problems and no concerns about, but can really cause altered mental status in people with decreased kidney function. Right? There's a handful of these medications, and honestly, with a creatinine of 1.5, I would normally not worry about that, but in this guy, you'd worry about it.
Bob, can we give Joel the UA, because that's something that really intrigued me the day of admission.
Do we have the UA, Stephen?
I don't have the actual UA. I think it was relatively bland.
It was bland, but it's bland, but the pH of 6.0 caught my eye.
Okay.
Yes, absolutely. Okay, so yeah, and then what about do we and this was on admission, this UA?
This is exactly on admission with the original bicarb of 15 and creatinine of 2.5.
Right, and so Dhruv,
Yes.
what would you expect that urine pH to be?
If his bicarb was 15,
Yes.
trying to think. Well, if he'd be excreting bicarb, you'd expect it to be at least decently high.
Well, but you nailed it. You called why he's got metabolic acidosis.
Oh, right,
It
because
was
he's
not-
excreting it in his diarrhea. So the pH should actually be low in the urine.
It should be. It should be. And then the other key part, because at the time of admission, we don't know where his kidney function is going to be. Now, it turns out this looks like it was pre-renal. Am I right? That's the assessment of the team.
Yeah. Mm-hmm.
And if you're pre-renal, what do you expect your urine pH to be?
That I'm gonna have to punt. I hadn't really thought about that.
Low. Acidic
Acidic.
urine. Yeah. And so we know he ended up being pre-renal. He behaved absolutely pre-renal. So this urine pH becomes even more abnormal. Now, if it turned out to be acute tubular necrosis, a urine pH of 6.0 would be not unexpected at all, right? It takes a lot of tubular function to acidify the urine. If your tubules aren't working, you're not going to be able to do that. But it turns out his tubules were working fine. They were working exceptionally well, and he still was not able to acidify his urine. So what is that pointing to? Alex, you got something for us?
I think that he may have an RTA in addition to the diarrhea.
Yeah, you wonder about that. You certainly wonder about that.
Joel, how good is the dipstick pH when we send it to the lab?
You know, it's not supposed to be so good. One of the problems is as this urine sits, it can off-gas CO2, and that can raise the pH, and so we don't know how fresh the sample is. If you read the methods, when they do precise measures, they always store the urine under oil to prevent that from happening. So that's a good point, Robert, is that we don't know. Let me just say, it's something that's remarkable. It's not an expected finding, and it would be a red flag for me when I saw that.
Joe, I trained in Detroit, and we used to put our urine sample for pH under mineral oil on plastic containers so we could make a hole below so we can get the urine drained without having to break the...
That's outstanding, right? That's how it's done. Yeah, that's right.
Yeah, that doesn't happen where we're practicing.
That doesn't happen anymore.
So here's the other question for y'all to consider. So we know the diarrhea could cause this metabolic acidosis. Could his creatinine of 1.5 and his estimated GFR of 35 in and of itself cause a normal gap acidosis? Alex?
I would think so. Yeah. I mean, that was something that we talked about at the beginning when his creatinine went from 2.5 back down to 1.5, but his bicarb didn't change at all. So I would have thought that it could have, to an extent, without a shadow of a doubt, caused some non-gap acidosis.
Right. So we always add mud piles or gold mark always has kidney failure as a cause of anion gap metabolic acidosis. But early anion gap acidosis, where this guy's living with the low GFR, that tends to be non-anion gap. They usually are able to still clear that. They don't accumulate sulfites and other things that are driving up the anion gap. So early CKD can be a cause of non-anion gap metabolic acidosis.
So how are we going to figure out, Dhruv, whether this is diarrhea induced or chronic kidney disease induced? We're gonna have to, right? Because we don't know what we're doing. Do you have any idea, Dhruv? If you don't, we'll ask Alex and see if he has any idea.
I think
Austin's all over it.
Yeah.
I think at that point you would check the the urine chloride and see.
More
So
than
it's
the urine
not just
chloride.
the urine chloride. So you're about to learn something, Drew. Alex, do you know what you do?
You check the urine anion gap, right?
Oh, urine gap.
Which
Urine
Right.
anion gap.
we can give you the urine anion gap. We'll give you the actual numbers, and then you can play with the numbers.
By the way, while we get the numbers in, he had a ileocecostomy back in 1995, but he didn't have any more ileal loops or diversions, Joel.
He's all been
Well,
reversed. He's got normal plumbing now.
Yeah, he had normal plumbing. So this was early on his Crohn's disease, no other unusual connections or interruptions in his GI tract. And what also got me into a rabbit hole was that he was started on a new medication right before his Bicarb starting to drop in the summer, a few months ago. Ended up being a unhelpful rabbit hole, but we got all excited.
He's on some map that you can't pronounce.
Adalimumab.
Yeah, I knew you couldn't pronounce it. So, Alex, now that you have the numbers, how do you interpret those?
So I'm trying to remember off the top of my head. I think you calculated the same way that you would a serum anion gap. I mean, is it the sodium minus? So we have sodium, chloride, and potassium. So I'd have to review exactly what the calculation is. But I know we're trying to see if we're trying to figure out if it's positive or negative. And I think negative would imply that the non-gap acidosis is coming from diarrhea, whereas positive would imply that it's coming from the kidney. But the exact calculation I'd have to review.
Good. So fortunately, we have an expert here to explain it to us.
Yeah. So it's the principle is the same as with the serum anion gap. You're trying to find unmeasured anions, right? And these are the anions that are bound to the hydrogen that's being added, causing the acidosis. The deal with renal tubular acidosis is the patient needs to excrete ammonium, NH4+, to get rid of the daily acid load. Like if you just look at the chemistry of the body, unless you could piss out stomach acid, the urine pH actually doesn't get rid of a significant portion of your daily acid load, literally less than 1%. So you can get that urine pH all the way down to 4.5, and it just doesn't matter for getting rid of the daily acid load that we generate. The way we get rid of the daily acid load is going to be as titratable acids, which means phosphates, and primarily, especially in the face of metabolic acidosis, as ammonium. And ideally, what you would do is you'd send the urine for ammonium, and if there was none, you'd be like, bingo, I've got renal tubular acidosis. And if it was high, you'd like, no, I got some GI losses. But your laboratory says, we're not going to reconfigure our machines to measure your ammonium. You're screwed. You got to find some other way to get it. And so what we do is we create this whole, we're like, well, ammonium is positive and the urine has to have a neutral charge. So we can just use an anion gap type process to see if there's an unmeasured cation. And that's what we're looking for. Unlike in the serum where we're looking for an unmeasured anion, all the things that are bound to the hydrogen, now we're looking for an unmeasured cation, ammonium in this case. And so we take the sodium and the potassium, add those together. In this case, we get 139. And then we subtract out the chloride. This is the only anion of consideration, which is 135. And if that is negative, that means if the chloride is greater than your sodium plus potassium, that means you have a bunch of unmeasured cations, presumably ammonium, and you have a normal, healthy response to metabolic acidosis. That's not what we have here. We don't have any room in these labs for a bunch of ammonium, which is what we would expect to have in this case. So this is a positive urinary anion gap consistent with renal tubular acidosis.
So here's the question for you, and this is what we struggled with, Joel. What urine anion gap do you normally see in people who have renal tubular acidosis? Do you see a number of 4 or do you see a number of 20 or 30?
it's just supposed to. It's supposed to be. It's just supposed to be positive.
Yeah.
It's a trap question, Joe.
Okay, I've been trapped. You got me. But this one, but it's a bit. And first of all, there's a display. There's a bunch of different urinary anion gaps depending on the type of renal tubular acidosis, and that potassium of 4.4 is bothering me. That's a very, very normal potassium for a renal tubular acidosis, which usually will be. It shouldn't be normal. It should be either hypokalemic or hyperkalemic. So I'm scratching my head on that one. I'm wondering, how did that potassium evolve during the hospitalization? Did it drop while you were taking care of him?
No, it remained relatively stable.
Yeah. So I'm going to throw out my hypothesis for you to argue against, Joel, or agree with me, but I don't mind either one.
Yeah.
So I think this guy has borderline ability to make ammonium. He has a GFR in the 30s, and he's okay until he starts losing bicarb. He then develops this diarrhea, and it's very interesting why he developed the diarrhea. Dr. Hudebert took a great history, and this guy was taking his pancreatic enzymes 3 times a day, but not with meals.
And surprise, surprise.
And we know that meals were doing it because they made him NPO in the hospital, and he had no more diarrhea. So,
Yeah, right. I see where you're getting. That he's got partial function. He can keep up somewhat, but as soon as he gets stressed, and in this case diarrhea, everything falls apart.
Yeah.
Right, because normally that amount of diarrhea, if you have normal renal function, you have to have big league diarrhea in order to actually get a metabolic acidosis, unless you have some impaired kidney function. Am I overstating that?
I'm on board. I'm on the Centaur train right here.
Okay. So I thought that the urine anion gap being approximately 0 sort of said that we had 2 things going on at the same time. Now, here's the big question, and this is the one that they didn't listen to me, but it's okay. They didn't listen to me.
We didn't listen to you. We decided to go in a different direction.
Yeah, right. They listened to me and they ignored it. Would you treat this? If you were going to treat it in the hospital, how would you treat it? And what would you do when you discharged him?
I'd put him on a bicarb drip in the hospital, bring up that bicarb, and then send him home on some oral bicarbonate if he can tolerate it.
So let's just talk about that for everybody. So let's say you have a patient come in with a bicarb of 15. Why do you want to correct it? And what do you mean by a bicarb drip? Because we have a lot of students here, a lot of interns who are, I hope I'm not insulting you, very unsophisticated when it comes to bicarb.
Okay, so there's a pretty solid pretty solid group of knowledge that looks at treating metabolic acidosis and chronic kidney disease. And if you keep patients bicarb above 22, they have slower progression of kidney failure. We've already assessed that this patient's got pretty bad kidney function in the low 30s. And has got a number of other health trouble, has had recurrent AKIs from his volume depletion from his diarrhea, his pancreatitis. This guy's at high risk for future kidney badness, and we probably should provide him every way to reduce that risk as possible. And treating metabolic acidosis is one of those things. And as an outpatient, you can give them sodium bicarbonate tablets. And so the tablets come in two sizes, 325 and 650. And oftentimes these patients will need up to 6 of the 650s a day to get that bicarb over 22. It's actually a little bit difficult to do depending on their kidney function and their inherent ability to neutralize that acid. In the hospital, and that's actually pretty significant, pill burden. In the hospital, quicker is to use IV bicarbonate. Typically what you'll do is you'll take an amp of bicarbonate, which is 50 milliequivalents of bicarbonate. You'll throw 3 of them in a bag of D5W. And that'll result in a sodium concentration of about 130 when you deal with the increased volume, right? Because it ends up being 150 milliequivalents of sodium bicarbonate in now what is 1.15 liters instead of 1 liter. And that divides out to be about 130 milliequivalents per liter. So close to isotonic and a pretty significant amount of bicarbonate. You're able to pretty quickly neutralize modest metabolic acidoses like these. That said, if you start going down the rabbit hole and try to find data that supports treating a bicarb of 15 for inpatients, I don't think you're going to find it. I think it's conventional that we do it, but I don't think it's evidence-based.
But long-term, so it's more.
That's right. But long-term, there's a pretty good body of evidence that supports that for slowing the progression of chronic kidney disease. And what happens? What is buffer if your bicarb is 15? What ends up buffering that acid? Because you don't have the serum bicarbonate to do that. And the answer is the bones and the proteins in the muscles. And this is just bad for you, right? And we see, you get a lot of bone deterioration with these patients with chronic metabolic acidosis, and you see a lot of malnutrition and increased inflammation from that. And that's not good for anybody.
Mm.
So Joel, I've heard you talk about this before. We can give bicarbonate tablets, and we even have a 1,300 milligram bicarbonate tablet at our hospital.
Yeah.
By the way, that has about 15 milliequivalents of bicarbonate.
Yes.
50 has about 7.5. It's roughly. We can give sodium citrate, Bicitra or Scholl solution. Mm-hmm. That's a lot to drink and it tastes horrible. But I've heard you talk about giving baking soda.
Yeah, yeah.
And so when you give patients baking soda, patients with chronic kidney disease, how much baking soda do you tell them to take?
A quarter teaspoon. I think 1 teaspoon is 60 milliequivalents. And so I usually dose it in quarter teaspoon increments. So there's always a board question of somebody who gets that instruction wrong and takes a tablespoon of the stuff, and they roll into the ER with pretty severe metabolic alkalosis. Like, it's pretty industrial strength bicarbonate. So you want to be careful with that. Make sure a patient understands what a teaspoon is, and ask them to measure it and not just to wing it. Kind of guess what a teaspoon might be, but a quarter teaspoon is going to be like the big pills that Dr. Center is talking about.
And so the last question, because this is really important when you're on the general medicine service, you'll see people that renal is following with chronic kidney disease, and they're on bicarbonate tablets. When you send someone out, let's say you're seeing someone who has a GFR of about 34 and they have a metabolic acidosis, and you're treating them, your goal is 22. Do you titrate? So do you bring them back, and if it's fallen down to 20, increase the dose? If it's gone up to 25, decrease the dose?
So first off, I kind of consider the bicarb on the Chem7 to be one of the less reliable indicators. You'll see that kind of float around quite a bit. I want to see a pattern of 2 or 3 in a row before I jump on treating it. Just mainly because of the evidence base. Like, yeah, there's a good evidence base here, but what's my most important job when I see these patients? Get them on an ACE inhibitor, get their blood pressure controlled, and probably in the future, and that future is not far from down the road, get them on an SGLT2 inhibitor, right? Those are the primary things you need to be doing. Once you got that all taken care of, I consider this like a secondary goal. And honestly, not so often at GFRs of 35. This is the CKD stage 4. We run a clinic called the Advanced Kidney Clinic. These are patients where we're fighting for every milliliters of clearance. We're trying to stretch out how long it takes them to go from a GFR of 20 to a GFR of I'm on dialysis. And those are the patients that I'm really focusing on the metabolic acidosis. Even with a GFR of 35, as low as that is, if you run it through the Tangri kidney failure risk equation, and why don't we do that? Do we have I'm going to bounce into this renal failure equation. Give me just a second.
Okay, and then I need to get you to your next recording.
I got 10 minutes. So this guy, how old was this guy? 72?
70, yes, mid-70s.
And we have no proteinuria?
No proteinuria.
Okay, so with a GFR of 35, age 72, male in North America, his chance of being on dialysis in the next 2 years is 0.3%. 99.7% no dialysis. If you stretch it out to 5 years, it's only 1%.
So,
Okay.
Right. And so you know, how much time am I going to spend
equation.
trying to slow the progression of kidney disease when he only has a 1% risk at 5 years? I'm not going to, that's not where the money is in this case.
so let me tell you what we did, Joe, and see what if it would make sense or not. Because he stopped having diarrhea, taking the Creon as prescribed. We wanted him to see how he will do in terms of his metabolic acidosis in 7 to 10 days. So he's going to have a short-term follow-up.
Yeah.
If the bicarb continues to be low, I think that we felt it was reasonable to start the bicarb. We felt that 7 to 10 days of a bicarb of 16 was not going to hurt him. And the decision was made because back in July, his bicarb was in the 20s. So he's not been carrying a bicarb of 15 for the last year and a half. He's been carrying a bicarb of 15, God knows for how many weeks. So we did not burden him with the sodium bicarbonate unless he needed it. So that was part of the reason. And to be quite honest, it was a short admission, so we didn't have a time to give him the bicarb drip. I wouldn't have mind as much that as giving him bicarbonate pills if I don't know if he can just compensate once his diarrhea is better.
Yeah, and the other thing, you know, and this is starting to get wonky and way off the kind of internal medicine trail, but this guy looks like he has a partial renal tubular acidosis.
It's interesting, no? Yeah.
Right, and oftentimes to make that diagnosis, you need to do a provocative test. You actually load them with acid and see if they're able to acidify their urine. And sometimes you can do that with furosemide and fludrocortisone, which is a way to stress the kidney to produce acidic urine. And, you know, again, we don't use these very often, but that would be the place for these types of tests.
Well, yeah, and actually we look at the literature to see if adalimumab can do this, give you an RTA. We couldn't find anything. That was the rabbit hole because he was okay until the summer, and then adalimumab, which he probably needed for his Crohn's disease, it makes his bicarb drop, but we couldn't find anything on the adalimumab or even any other TNF inhibitors literature. So we were left with we were concerned with that pH and that urinary anion gap, that there might have been a partial RTA, but we couldn't fish out a good explanation. Certainly,
did you guys do a multiple SPEP or UPEP?
It has been done in the past, so we didn't repeat one.
So, Joel, in your last several minutes, what are the 2 or 3 most important things that we went over in this case that you want all of the learners to really own?
Okay, 1, the non-anion gap metabolic acidosis. Decrease bicarb with no anion gap or an anion gap that's not very high. Make sure you're dealing with an acidosis. Don't go down the rabbit hole, especially a guy who might have liver disease. We know liver disease, classic cause of respiratory alkalosis. That would be the number 1 thing. Number 2, patients who have a non-anion gap metabolic acidosis, you want to think of 3 things. I thought the comments in the chat were outstanding tonight, but there's 3 things that you're going to do that. 1, chloride intoxication. Someone suggested maybe this guy got a lot of fluid resuscitation in the ER before he was addressed, and that fluid resuscitation, if it was normal saline, can cause a non-anion gap metabolic acidosis. Right on, absolutely could happen. 2, it's diarrhea, and it's almost always diarrhea. In this case, we think in the end it was diarrhea. And 3, it's kind of less likely, but renal tubular acidosis are possible, and especially on that initial UA, like learn to interpret the UA, because you get them on all these patients and they have a ton of information. And right off the bat, the very first test you did, you're like, boy, that urine pH, that don't look normal. Urine pH is 6 in the middle of an acute injury like this. Again, if it was acute tubular necrosis, that would not be remarkable, but it turns out it was all volume responsive. That is highly unusual and very suggestive of a person who cannot adequately acidify their urine, and that turns out what was the case. It's amazing how much of the case was revealed on the initial BMP and the initial urinalysis.
Great. If everybody could raise their applause signs for Joel. Joel, we appreciate so much you joining us.
This was fun. This was a lot of fun. Anytime you have a case like this, I would love it. This was great. Thank you, guys.
Yeah. Well, it was great. Have a good time recording, and please tell everybody about your renal podcast. If people really talk about getting down rabbit holes, if you listen to his podcast, they go down some rabbit holes you wouldn't believe.
It's Nerd City. We call it Freely Filtered. It's 5 nephrologists just going deep on recent high impact articles in the nephrology literature. It's a lot of fun. But we nerd out.
Joel, are you at St. Joseph? Is that correct?
I'm at St. John's on the east side.
St. John's. You work with Lou Sarabolas by any chance?
Oh my God, he's our chief of medicine.
I know. Say hello to him. I was a resident when he was the chief of ID at Henry Ford.
I will do that. Yes. Right.
Great.
Lou Sarabolas, whose claim to fame, he discovered something. I don't know. Have anybody ever heard of methicillin-resistant Staph aureus?
Uh-huh.
I heard
He
of
discovered that, right? As a fellow.
And then,
So,
and then
so Joe, a twofer. I also trained under Lou Sarabolas at Henry Ford.
That's outstanding. Yeah, Lou's great. Lou's great. I will give him give him your best.
Joel, what article are you taking the deep dive into today?
We are looking at a randomized controlled trial of fluid restriction in SIADH.
ooh,
Yeah.
do we have a case for you?
Oh, I love sodium. That'd be awesome.
Okay.
Okay.
Thanks, everyone. I think this was a lot of fun, and I'm clapping for Joel.
You guys take care.
Mm.